Assalamualaikum and good morning, both to the Malaysians and also the Japanese. We are very honored to have a combination of collaboration between two countries this morning, between Malaysia and also Japan. And today we have two talks, one from the emergency physician and the other one from a neurosurgeon, which were kindly enough to join us to share his knowledge this morning. So I'm going to start off with Dr. Vila. She'll be giving the talk first, followed by Dr. Junichi Takeda. So Dr. Vila is an emergency physician from the Department of Emergency Department of Hospital Sultan Abdul Halim, or also known as Hospital Sungai Petani, which is located at the northern part of Malaysia. She obtained her undergraduate degree from AIMS and postgraduate degree from Universiti Kebangsaan Malaysia. And she's actively engaged in various life support courses as a speaker and instructor. Yes, Vila, I can see that. Very active. She is heavily involved in stroke activation and protocol. And she's actually one of our members who actually been actively involving in the activities of neuroemergency special interest group. So without further ado and taking much of your time, Vila, please proceed with your amazing lecture today. Thank you.
Thank you very much, Nina. Okay, a very great morning for everyone and also for our special guest today for Dr. Takeda. Welcome to the Japan and also Malaysia. I'm very privileged to be the first presenter when it's involved so-called international collaboration. Thank you, thank you. Okay, the topic for today's discussion will be an update on the intracerebral hemorrhage management. We have a various reference for this topic. I have picked up a few from the American Heart Association and from the Canadian Stroke Update and the CPG of the Malaysia, and also even I had a look on the Japanese guideline for the stroke update. I have no special conflicts of interest with the material presented in this presentation. Okay, stroke in general is the third leading cause of mortality in Malaysia. I'm pretty sure it has a similar number in the other countries throughout the world. Compared to the ischemic stroke and the intracerebral hemorrhage stroke, the intracerebral hemorrhage has a little percentage compared to the ischemic. However, the effect of the intracerebral hemorrhage is more devastating than the ischemic stroke. It has a higher mortality and also a very deep neurological deficit. In the current status, the recurrence rate of the hemorrhagic stroke is about 3 to 4% within a month, and in a year, it goes even up to 40%. However, if you look back for the last decade, there is a significant reduction in the number of mortality and of the number of severity of the neurological deficit with the presence of the dedicated stroke team. A great kudos to the team. Okay, this will be the gist of the talk for today's presentation. What is the main principle of the management of the intracerebral hemorrhage? Initiating from the blood pressure reduction, the reversal of coagulability, the role of anti-edema, and when do they need a surgical intervention or surgical measurement. Okay. There was a recent journal published in the year 2020 by our clinician Zifang Li and his team. He detected that hematoma expansion in intracerebral hemorrhage is a most single predictor to identify the severity and the prognosis of the patient. The moment patient develop an intracerebral hemorrhage, there is a risk of expanding of the hematoma, and it's the highest risk in the first 3 hours. I beg everyone to take note. The highest risk of the expansion is the first 3 to 4 hours, which means they are still within our triage, our pre-hospital team, and our emergency team responsibility. I'm pretty sure the others also involved, but the responsibilities fall more on the emergency side. if you see in these charts, the highest expansions occurs in the first 3 hours, which is about 36%, and slowly it gets down. There are few signs in the CTA which can predict the expansion of the hematoma, such as the spot sign, which described as the presence of heterogeneous hematoma within the blood collection area. This is the spot sign. And another signs which we can delineate the evidence of the hematoma expansion will be your leaking sign. Why is it so significant, the intraventricular hematoma expansion predict the severity? If you have a view on this graph, the increase the size of the intraventricular hemorrhage every 10 centimeter, the probability of the survival 30 days, the probability of the 30 days mortality in a patient exponentially rises. So this is why we need to give a very important measurement to be taken in order to reduce or remain static the hematoma size in the intraventricular hemorrhage. How do we measure the intraventricular hemorrhage size? This can go by the rule of A times B times C divided by 2. A will represent the axial height of the intraventricular hemorrhage, followed by the perpendicular axis, and times with the number of slices which contain the cerebral hemorrhage divided by 2. Okay, the management of the intracerebral hemorrhage patient is initiated from the triage itself. Why I'm mentioning it start from the triage itself? About 20% of the patient, the moment they develop the symptom and arrive to our ED itself, they tend to deteriorate. So the management should start at pre-hospital scene itself. So again, the responsibility falls to us. Those patients who have a significant drop in the GCS may require airway stabilization, followed by cardiovascular stabilization, and rapid transport to the nearest neuro center if possible. I'm pretty sure in Malaysia, this is something that is developing at the moment, but not to worry. We stabilize the patient, we transport to the nearest hospital, and make sure we inform the team earlier. What are the cases we are bringing in? What is the current GCS? What is our probable diagnosis and what the patient need? This is mainly in order to reduce the time taken for the imaging subsequently. There are studies shows that there are few signs and symptoms have a higher odds ratio favors towards the intracerebral hemorrhage. Example, a sudden onset of a headache, followed by a persistent vomiting and significant drop in the neurological, favors more towards the intracerebral hemorrhage rather than the ischemic stroke. We should have a fast-track concept when dealing with a stroke patient. This can be achieved by having an algorithm, a stroke protocol, which is currently actively being carried out in Malaysia. I'm pretty sure it's being carried out in all the developing and also developed countries. In future, telemedicine is one of the fields that we need to look more in details in order to establish a well-established stroke team. Those patients who are having stroke, if possible, all those patients with a stroke with a significant GCS drop requires an ICU care and a stroke unit. Why is it so? Because a study shows patients who are admitted in a stroke dedicated unit, the survival rate and the prognosis on the neurological deficit is better because the staffs there and also the team are specifically trained to identify a significant drop in GCS or in their neurological, and what is the subsequent appropriate management needed to be taken. A single way of measure is assessing the gag reflex. It's one of the important tools to prevent a complication in a stroke patient, to prevent their aspiration pneumonia. So a simple step, which can further reduce the mortality and morbidity in this group of patients. The initial aggressive care should be provided to all the patients who present with stroke. We should not have a point of view that those patients who have a very low GCS or significant drop in neurological deficit should not receive the optimal care. Avoid the concept of do not attempt resuscitation orders, because this can have a catastrophic, we can have an abnormal, or it's not, we won't call it abnormal point of view. We will say that we will reduce the optimal care, optimal medical care for this group of patients, because this hence will reduce the, will lead to a poor outcome on this group of patients. So in general, all the patients who present with stroke requires initial aggressive care and delay the prognostication factor up to 24 hours. Okay, what will be the best neuroimaging when we are dealing with the intracerebral hemorrhagic group of patients? We have varieties of modalities, but in emergency department, a plain CT is significant enough, which has higher sensitivity and specificity to detect the intracerebral hemorrhage. In order to identify the pathology, what caused the intracerebral hemorrhage, most of the time it will be hypertensive bleed. But if there is other anomalies, you may proceed with the MRI, CTA, or CTV. Okay, now let me go to the component of the management of the reverse the INR. Okay, study shows 20% of the patients who have an intracerebral hemorrhage are related to anticoagulant hemorrhage, such as warfarin-related or the new group anticoagulant. In old traditional school, we were taught to use the FFP as an agent to reverse the anticoagulant bleed. I'm pretty sure it is being still carried out now, but we have a recent agent, which is your prothrombin complex. Evidence shows that patients who presented with anticoagulant related intracranial hemorrhage, the first thing you should stop the agent, followed by giving a vitamin K about 10 mg, 10 milligrams slow bolus, 5 to 10 minutes, followed by giving a prothrombin complex. Why we are preferring more to prothrombin complex? Mainly because it does not require TOR. It has a lesser infection. It does not cause an infection, and it does not cause a volume-related issue. You're going to use about 20 to 50 ml of it. However, on the other end, FFB, it requires a cross-match. It may cause infection, and you need a larger volume of FFP in order to reverse the INR. Comparatively, there's a studies done by the case central. If you have the view on this table, the effective of hemostasis achieved better in prothrombic complex concentrate, and the INR is reduced at less than 1.3 at 30 minutes, significantly higher in a prothrombin complex group. However, it is no harm if you still transfuse FFP if its PCC is unavailable. There's no harm. So I'm not telling I'm favoring towards the PCC, but PCC is comparatively better to FFP. Even the 9th edition of American College of the Chest Physician Guideline, they recommend rapid reversal of vitamin K with a 4-factor prothrombin complex rather than FFP with the major bleeding due to warfarin therapy. How about the other new oral anti-agent coagulant, which is a factor 10, direct factor 10A inhibitor? If you look at 5 years back, not much antidote were available. Thanks to current study, dabigatran, it has a reversal agent, which is idarucizumab, name called by Praxiban. Even you can dialyze the patient, you want to reverse the dabigatran. What's the good thing of the new oral anticoagulant is it has a very short life. up to 2 to 12 hours only. So during the clocking time, you may need to ask the history of when was the last consumption of the NOAC. If it's less than 2 hours, studies even suggest to give activated charcoal to eliminate the NOAC. And those who are on abivaxan, there's a newer antidote reversal agent which is called Endoscopic. I'm sure it's not available in Malaysia yet. Not to worry if you do not have either one. Your PCC can still save your patient's life. It's just a little bit delay in terms of achieving the targeted. So the dose will be as how it's given here. If it's a 4-factor prothrombin, you give 1,500 to 2,000 units over 10 minutes. Check the INR after 15 minutes, and you may repeat if required. If it is 3-factor prothrombin complex, you may give 1,500 to 2,000 units over 10 minutes. Check the INR after 15 minutes, complete the infusion. Required further if it's the INR less than 1.5. If neither is available, you may give a FFP2 units by rapid infusion. Check the INR 15 minutes after the completion. If INR more than 1.5, give additional 2 minutes. And not to forget your vitamin K, 10 milligram, IV, 10 to 20 minutes. It would start to, the mechanism of action of vitamin K will initiate within 10 minutes and achieve the highest mechanism of action after 24 hours. Okay, you may ask me, when are we going to start the reversal for the anticoagulant intracerebral hemorrhage? Are we going to wait for the INR to be released? Study shows if there is a significant history suggestive of intracerebral hemorrhage with evidence patient on anticoagulant, you may start the reversal agent. Okay. This is the only studies which I could manage to find whereby they have a guideline to compare the European guideline and the Japanese guideline, but it's a little bit backdated, but not much difference if you compare on both the studies, on both the guideline. In Japanese guideline, those patients who have a hypertensive intracerebral hemorrhage with a normal coagulation, the blood products are not recommended. Where, how on the other end, ICH with the abnormal platelet count or bleeding tendency, you may consider blood products such as fresh frozen plasma. There is no adequate scientific evidence on the capillary stabilization or antiplacement agent. Okay, those who have an intracerebral hemorrhage on anticoagulants, stop the warfarin, normalize the prothrombin using a vitamin K and blood product. You may use a PCC as how it's being suggested in the European guideline. Okay, how about factor 7A? We all aware that factor 7A is very expensive compared to the previous treatment which I've mentioned. It do achieve a hemostatic. However, it does not improve the functional outcome or the survival rate after the intracerebral hemorrhage. This is well proven in the studies of Stephen A. Meyer on the efficacy and safety of the recombinant activated factor 8 for acute intracerebral hemorrhage. But bear in mind, those patients who have an underlying factor 7 deficiency and develop hemorrhage, yes, you may give this group of patients the factor 7 a recombinant as a replacement, not as a general treatment. But in future, this is a area of to be developed further. Okay, how about role of transomic acid in intracerebral hemorrhage? The dose remains same how we given for the intra-abdominal injury, 1 gram stat followed by 1 gram by infusion. Okay, if you look at the TEACH2 study, the modified ranking score of more than 3 is almost same in those groups who received the transomic acid and also in those groups who received the placebo. So in general, there's no harm but there is no difference in functional status in between the mortality between the two treatment groups, despite early reduction in the hematoma. So generally, it does not give any effect to the intracerebral hemorrhage or in terms of the mortality and the survival outcome. And what is the role of platelet transfusion in intracerebral hemorrhage? Generally, again, a big no for platelet transfusion. It is not recommended for the treatment of acute intracerebral hemorrhage in patients who are taking antiplatelet therapy. Example like a clopidogrel or those patients who are taking aspirin. A big no. However, those patients who have a significant platelet deficiency disease like your idiopathic thrombocytopenic purpura, yes, you may transfuse the platelet as required. Okay, now the big dilemma. What is the ideal blood pressure target in spontaneous intracranial bleeding? Each department will come up with their own value of blood pressure control. Back in 2004, a study done by our Japanese friends, it shows that a rise of the systolic blood pressure will have a significant impact on the hematoma enlargement. The greater the pressure systolic, the greater the volume of the intracerebral hemorrhage hematoma. So this study shows the intracerebral bleed is directly get affected by the high blood pressure. But bear in mind, are we going to be rapidly reduce the BP? Because on the other side, we need to take care of the area of the penumbra, which surrounds the hematoma area. So that we need to be tally, or we need to be outweigh the benefit and the risk when we are dealing with the blood pressure control. Most of the time, the patient who develop intracerebral hemorrhage are commonly a hypertensive patient. If you look at their cerebral blood flow compared to the cerebral perfusion pressure graph, they already shifted to the right. So the upper limit of a normal BP for them will be towards the higher side. They won't be sitting on the ideal range, which is about 120 to 130. So a significant care has to be given important. The blood pressure reduction could theoretically reduce the hematoma expansion, but it may impair the perfusion of penumbra surrounding the hematoma. This could cause a necrosis, leading to worsening edema or intracranial pressure. So there comes these two famous trials. It is Interact 2 and Attach 2 trial. It was an open label randomized control trial where in Interact 2 trial, there were about 2,839 patients assessed and treated and monitored within the 6 hours of onset of intracerebral hemorrhage. 719 patients were treated with to a blood pressure of less than 140, and 786 were treated to modest systolic BP of less than 180 millimeter mercury. The primary outcome of modified ranking score 0 to 2 versus 3 to 6 at 90 days. The secondary outcome was to look at their safety quality of life. And finally, the conclusion, there were no difference in the primary outcome, almost no difference. However, in summary, you may reduce the systolic blood pressure when it's above 220. You need an aggressive reduction, preferably using an IV agent. And they suggest the nicardipine and IV labetalol, which is 20 bolus, may repeat every 10 minutes. Subsequently, you may reduce the blood pressure stepwise, typically over 1 to 2 hours to reduce about 140 to 160. And always keep on hand, look and monitor on the neurological deterioration. Okay, in 2017, the AHA guidelines mentioned that neither the two key trial, which is your Interact and Attach trial, evaluating the effect of the lowering BP in acute period after spontaneous intracerebral hemorrhage, meet their primary outcome in reducing death or severe disability at 3 months. This is a recent, quite recent also, sorry, this is about 10 years ago, I'm sure. Studies was produced by our Japanese clinician, shows that a minimum systolic blood pressure of approximately 120 to 125 after admission is associated with beneficial impact on reduce the risk of early neurological deficit. This is again the guideline comparatively from the European guideline and Japanese guideline. Not much difference. They are using they reduce the systolic blood pressure of less than 180 and mean arterial pressure of 130. But they did not suggest any specific hypertensive drug. However, they asked to possibly avoid the vasodilator, which is nitrate, because this can induce a brain hypertension. Okay, again, now we have to enter to the surgery component. Who requires emergent surgery? All the patients with a significant intracerebral hemorrhage? Again, a big no. The neurosurgeon group have done various and multiple studies to identify which group will be benefit most from the surgical intervention. And studies have shown that the observational data suggests that individual with a hematoma more than 3 cm in diameter, those patients with a mass effect causing a brainstem compression, and a significant hydrocephalus secondary to ventricular obstruction may require a surgical intervention. There are a few trials famous for this surgical intervention, especially a stage 1 and stage 2, which involves a randomized control trial involving a 601 patient to predict optimal maximal benefit from the surgery based on the results. Had a superficial hemorrhage less than 1 cm from the cortical surface, had a hemorrhage volume of 10 to 100 ml, had no interventricular hemorrhage. A surgical intervention was done to them. The patient was randomized to early surgery versus conservative approach. The outcome were nearly identical between this group. And in conclusion, there were no benefit for early hematoma evacuation. Yes, EVD is necessary in those groups who have hydrocephalus with a significant GCS drop or evidence of a brainstem compression. Yes, you may enter in. Unfortunately, overall evidence suggests that ventricular drainage increased the survival rate without increasing the likelihood of the good neurological outcome. Okay, this will be an upcoming field in intracerebral hemorrhage, which is minimally invasive surgery plus RTPA infusion in intraventricular, whereby the neurosurgeon have developed their experience to facilitate to remove the blood clot in the ventricle in order to improve the survival on this group of patients. The conclusion of the study, it is a very safe procedure and it reduced mortality compared to the medical management, but it does not improve the functional outcome. However, on the surgical point of view, the hematoma volume reduction up to less than 15 ml may associated with functional outcome. So in future, this is a field that needs to be given more weightage to develop. Yes, this will be all the necessary preventive measure to facilitate the improvement of the intracerebral hemorrhage group of patients, starting from the elevation of the head up to 30 degrees, mild sedation for the agitated patient, the usage of antipyretics because the rise of temperature every 1 degree will lead to increase the metabolism rate about 10%, which requires more consumption of oxygen and which need to increase the cerebral perfusion. The head positioning and device placement at the neck should reduce in order to prevent the venous congestion and facilitate the cerebral venous outflow. The choice of solution, isotonic, is the best solution in order to maintain the osmolarity within the brain and maintain a serum sodium of more than 135 milliequal. And how about the role of hyperosmolar therapy? Usually, this hypertonic solution is kept till the end and usually is given to the patient when there is evidence of coning or herniation syndrome. We may use a concentration up from 23.4% up to 3%, and also the other option will be mannitol. The initial dose of mannitol will be 1 to 1.5 gram per kg of a 20% solution, followed by bolus of 0.25 to 1 gram per kg as needed to target osmolarity of 300 to 320 milliosmol. Additional doses can be given as frequent as once an hour based on the initial response to therapy with the anticipation of a transient drop of BP. As I've mentioned, this is just a mode of therapy to buy time in those group of patients who are going for or awaiting an emergent surgery. Not all the intracerebral hemorrhage patient requires this hyperosmolar therapy. It is effective in reducing the ICP, but there is no firm evidence that it has a different. It has no firm evidence in improve the outcome. Okay. These are the salvageable therapies which we can apply to those group who are towards the end or there's evidence of significant raised intracerebral pressure, like a hyperventilation. And hyperventilation technique also, it was taught in a traditional school way. It is not the management, it's just to buy time again. Unless the patient going for a definitive surgery therapy, yes, you may apply this hyperventilation, whereby you may tend to target a PCO2 of 30 to 35 millimeter mercury. A further reduction of the partial pressure of PCO2 will cause a significant hypoxia around the brain and also will have an effect on the penumbra area. Pharmacological coma can be reducing the cerebral metabolism, which lowers the cerebral blood flow and reduce ICP. The choice of medication will be barbiturate. Propofol is another famous agent in order to sedative agent to reduce the intracranial pressure. If all these measures failed, you may use the neuromuscular blockade to reduce the ICP. This can be used in those patients who are not responding to analgesia and sedation alone, as muscle activity can contribute to the increased intracerebral pressure by raising the intrathoracic pressure, thereby reduce the cerebral venous outflow. The drawback of this agent will be you increase the patient for pneumonia and sepsis. And hypothermia can reduce the intracerebral pressure through the reduction of the cerebral blood flow and metabolism. But there is no any obvious study showing that the benefit with the acute intracerebral hemorrhage. Okay, how about seizure management? In intracerebral hemorrhage, the seizure can be divided into two groups, early versus the late seizure. Early seizure commonly occurs mainly due to the transient neurochemical changes associated with acute intracerebral hemorrhage. However, the late seizure are mainly due to the structural changes. Studies shows there's no role of giving a prophylaxis anti-epileptic medication to intracerebral hemorrhage patient. Only start the anti-epileptic medication in those patients who presented with seizure during the intracerebral hemorrhage. Okay, the take-home message, time is brain. Every minute is accountable after onset of the symptom. Our main aim when you're dealing with the intracerebral hemorrhage, prevent the hematoma expansion by taking all the necessary measurements, handling the blood pressure, early reversal of the anticoagulant, blood pressure control, early referral to the neurosurgical team, a best dedicated stroke unit, and avoid the attitude having do not resuscitate in a severe group. This will be my references.
Thank you very much,
Yeah,
Dr. Vila.
I am done with my presentation.
All right.
Thank you.
That was a very interesting talk. I guess it covers quite a number of recent updates as well as the questions that you may have, such as what's the benefit of starting patient on hyperosmolar therapy, when to start it, when you start, should you start patient on anti-epileptic drugs or not, and what's the BP, targeted BP for patient if they come with intracerebral hemorrhage. So I would like to open the floor to the audience who are listening. If you have any question to ask to Dr. Vila, you may unmute yourself and ask, or you may type it inside the chat box and I'll read it up for Dr. Vila.
Yes, please.
Okay, anyone has any questions? Okay, Vila, I have
Yes,
one
Nina.
question to ask you. As for those who are working in a center without immediate CT scan available, mainly covering those who are working in the district hospitals. So if you have a suspicion that patient might come in with intracerebral hemorrhage, they have low GCS, their pupils are unequal, you need to intubate to protect the airway of the patient. Should you or should you not lower down the BP? And if you should, what is the safe target that you can lower down? Because these patients still have a probability that they might be suffering from ischemic stroke. So what's your take on that?
Okay. In general, Nina, if you look at the guideline, there's no any specific guideline I've mentioned about this. But as I mentioned earlier, we have a certain sign and symptom which favors, with the evidence of studies, favors towards the intracerebral hemorrhage. For example, as I mentioned, a sudden onset of a headache, followed by persistent vomiting and a significant drop in the neurological deficit, and
Vila? Hello, Vila. Vila, can you hear me?
Oh.
Hello. Sorry, I think you the internet connection somehow went off for a while. Can you repeat again?
Okay. Can you hear me, Nina?
Yes, yes.
Okay, Nina. Okay. Again, it depends how near is your stroke unit, stroke center. Okay, and another point to look in is what was the presentation of the patient. There are few signs and symptoms, as I mentioned earlier, which had a high odd ratio of favors towards the intracerebral hemorrhage, like a sudden onset of a headache, vomiting, a significant drop in neurological deficit with high BP. Okay, those patients who have a blood pressure at 20, they may require to reduce the blood pressure. It may facilitate in order to treatment and also for the prognosis effect. You may give a single dose of medication like labetalol, 5 to 10 milligram bolus, and reassess the blood pressure. Let's say this patient is a candidate for the stroke activation. Again, you are not doing harm to the patient because the target of blood pressure in this group of patients will be 180 and 100, I suppose, right? Unless you're away from the stroke center, again, you only will give an antihypertensive agent if the blood pressure more than 220. So I think anything value about more than 220, there's no harm you're giving the medication. So you keep your range 220 to 180 till you reach the stroke center or nearest hospital. That will be my answer.
Okay, thank you for your answer, Vila. I think because the dilemma that the medical officers will have if they are working in a center which is located far away from a CT scan, from a center that has the availability of CT scan. So I have one question which is being typed inside the chat box. Hi, good morning, doctor. What are the best sedating agent for intubation in intracranial hemorrhage, ICB?
Okay. If you have seen our previous lecture by our prof and everything, they suggest one of the agent will be propofol, will be one of the best sedative agent because it has a various effect. Despite having the sedation effect on this patient, it also have reduce the, as I mentioned, reduce the neurochemical activity. So you can stabilize the patient's brain function for the time we are handling the, when we are targeting for the neuroprotective concept. So propofol is one of the agents. Any other agent you want to suggest?
All right, so I hope that answer Dr. Wan's question. I do agree because sometimes you're having trouble to basically reduce the blood pressure of the patient, and propofol is one of the best agent. I started liking propofol more after the lecture we had with neuro anesthetist Prof Wan previously. So before we go into our next lecture by Dr. Junichi Takeda, just would like to inform that if you do not have a PCC, in Malaysia, for your information, we only have 3-factor PCC. That's what that being updated, and this is available in Pusat Darah Negara, our national blood bank center. So you may work with your pharmacist. This is free. You can import it to go to Sabah and Sarawak. They will make it available for you, and therefore you can use PCC. PCC is actually very good, and you do not have to infuse patients with FFP, yes, which may have potential infectious disease later on for the patient. And it has a better outcome in terms of reversing fast the hematoma expansion and also bringing down the INR as fast as possible. So thank you very much, Dr. Vila, for your exciting talk. All right, so without further ado, I would like to invite our next speaker, who is a Japanese neurosurgeon. His name is Dr. Junichi Takeda, and he's the assistant professor of Department of Neurosurgery. So he worked in the Nagasaki University in 2002, and he has a few working experience in NTT Medical Center Tokyo, as well as International Medical Center Saitama Medical University. And currently he is based in Kansai Medical University. So he is a board certified fellow and trainer of the Japan Neurosurgical Society, board certified fellow of Japan Stroke Society, board certified fellow of Japanese Society for Neuroendovascular Therapy, and Japan Disaster Medical Assistant Team. That's very interesting CV of yours. So without further ado, I may invite Dr. Junichi Takeda to share his slide and proceed with his exciting talk this morning. So his topic will be about endovascular approach in non-traumatic intracranial hemorrhage.
Thank you, Dr. Nina. Good morning, everyone. Good morning, good afternoon, everyone. I'm Junichi Takeda. Do you see? Can you see?
Yes,
okay.
we can.
Okay. Hi, I'm Junichi Takeda, Department of Neurosurgery, Kansai Medical University Hospital. It is a great honor to be given the opportunity to present at such a meeting. Today, I would like to talk about the utility of the neuroendoscopic surgery for intracranial hemorrhage. I have no disclosure. So there are 3 topics on the agenda today. I am the neurosurgeon, so mainly talk about the surgery for ICH. First of all, I would like to introduce my hospital. So our hospital is located in the west country. We are located between the city of Osaka and Kyoto. Osaka is the second largest city in Japan after Tokyo. As you know, Kyoto is a historic and beautiful city, full of temples and shrines, and the most visited city by the foreign tourists. By the way, today's moderator, Dr. Nina, was staying in Akita Prefecture, which is located in the north of the Japan. It's famous of the full of snow and Japanese traditional alcohol, sake. Our hospital is a white building, the left side, and university is a great building on the right. My hospital has 751 beds and performs 11,401 operations a year. Hybrid operating room was installed 3 years ago. This operating room is equipped to perform the craniotomy and interventional procedure at the same time. It is used for the operation such as AVM. To introduce our emergency care workflow. Basically, an emergency physician will take the initial response to the care that was transported by emergency. If a stroke is suspected, a neurosurgeon or a neurologist will cooperate with the emergency physician at the same time. Once a diagnosis has been made, the patient is ready for treatment. The neurosurgeon and the neurologist will be treated at the SCU, stroke care unit. In the case of trauma, the emergency physician is basically in charge, but depending on the site of injury, the patient may be treated in the ICU in cooperation with the neurosurgery or orthopedic surgeon or plastic surgeon. The neurosurgeon and the emergency physician must always have a good working relationship. So one of our neurosurgeons is always dedicated to the emergency medicine department. So let's move on to the next topic. Topic 2 is evidence of the surgery for ICH. This is AHA, American Heart Association guideline for ICH, and Japanese stroke guideline. Japanese guidelines have just been revised this year. This is a AHA guideline for the surgical treatment for ICH. First, it says cerebral hemorrhage should undergo surgical removal of hemorrhage as soon as possible. On the other hand, supratentorial ICH, it says usefulness of surgery is not well established. For minimally invasive surgery, stereotactic or endoscopic surgery is also described as uncertain. This is Japanese guideline. Terminal hemorrhage surgical evacuation might be considered for the hematoma volume more than 31 millimeter. Thermic hemorrhage surgical evacuation is not to be recommended. Subcortical hemorrhage might be considered for the hematoma less than 1 centimeter from the brain surface. Cerebral hemorrhage, surgical evacuation should be undergo for the hematoma larger than the 3 centimeter diameter or with hydrocephalus. Brainstem hemorrhage not be recommended. Surgical endoscopic or tactic surgery might be considered for the ICH or IVH, intraventricular hemorrhage. So summary. Cerebral hemorrhage have evidence for surgery. Supratentorial ICH have not clear evidence for surgery, but there's a group for surgery may be useful or large terminal hemorrhage or superficial hematoma. Minimally invasive surgery may prove to be useful in the future. The first publication of the current concept of endoscopic hematoma removal was by Japanese Dr. Nishihara in 2000. The most important concept is the use of the transparent cyst to prevent the intraoperative disorientation. So this is a schema of the endoscopic hematoma removal. The procedure is performed with the 2.7 millimeter OD rigid scope and suction tube in 8 millimeter ID transparent cyst. The suction tube is designed for the endoscopic use, connect directly to the coagulation system. So allowing to coagulation hemostasis to be achieved at the end of the suction tube. The transparent cysts have an OD of 10 millimeter, so the operation can be performed by the perforator, slightly enlarging perforator. No need to craniotomy. So topic 3, we will show you a video of the real endoscopic procedure. Case 1 is a 74 years old woman with a terminal hemorrhage who presented with a mild disorientation and left hem paralysis. She underwent the endoscopic surgery for the hematoma volume of the 15 millimeter. Perforator was performed at the site of the right anterior horn puncture. So suction tube and then the scope advance in the transparent cyst. So we can see the surrounding the brain tissue. So we know where we are in the relation to the hematoma. So hematoma usually had the soft parts and hard parts. So hematoma is gradually removed from the front towards the back. The transparent cyst is removed in rotational motion, gradually moving towards the back. So this is a soft clot, can be evacuated. Hardest part is often so the source of hemorrhage. So in case of terminal hemorrhage, the deepest part of the hematoma is just above there, the perforating artery, a name of lateral lenticular storage artery, LSA, which is the source of the hemorrhage. So this is a hard plot.
Yeah.
So hematoma was almost removed, and the cavity, hematoma cavity, in the deep side of the hematoma cavity, there is a small artery, so perforated. So this is the map. Almost remove the hematoma, and there's a small artery. Such a small artery is a cause of the hemorrhage. It's a coagulate hemostasis. This section 2. So here is a coagulation. So this and the hemostasis. So such small artery now here is coagulated. Almost hematoma removed, and finally fill the absorbent cellulose. So hemostasis. So this is the end of the operation. The pre and post-operative CT scan confirmed that hematoma was being almost completely removed. The operation takes about 1 hour. Case 2 is a case of a Transomic hemorrhage with intraventricular hematoma. Here is a 5-year-old man came to our hospital with a severe disorientation. There were many elements of the intravascular hemorrhage, and it was judged to ventricular drainage alone would not improve the patient's condition. So this case was treated with a bilateral anterior horn puncture. So this is inside of the left lateral ventricle. So if the endoscope became cloudy, so like that, The water is used to create a cloud, and procedure continued. This is you can see the foramen of Monroe. You can see that. This is the hemostasis situation. This is the suction tube. Yes, here. Suction tube is used to carefully to identify the point of bleeding, and electrocoagulation is performed. The most important aspect of the endoscopic surgery, now bleeding. So endoscopic surgery is that hemostasis is more difficult to achieve than the with craniotomy. So especially when the arterial hemorrhage encountered, it is impossible to see anything in the left surgical field. The calm aspiration is the key. So this is aspiration of the hematoma from the body of the lateral ventricle. So this is the lateral body of the lateral ventricle to the posterior horn. So you can see the inside of the ventricle. So on the upper side, you can see the ventricular drainage, tip of the ventricular drainage. So this drainage tube inserted from the right anterior horn. Yes. The endoscopic surgery is prone to disorientation. So, such as ventricular drainage or shunt tube can be important. Important landmark can be an important landmark. So it is clear now, very much now. So postoperative CT show the hematoma in the ventricle is almost completely removed. So if ventricular drainage alone may require the prolonged tube placement and ICU stay. So in this case, the ventricular tube could be removed after 3 days. This is the last case. Case 3, as intraventricular hematoma in 59-year-old man who presented to the hospital with impaired consciousness. And left caudate head seems to be the source of the hemorrhage, but the hemorrhage are almost confirmed to the ventricle. This is a good indication for endoscopic surgery. So in this case, we perform the endoscopic third ventriculostomy, ETV. So ETV after removal of the hematoma evacuation. So ETV is a procedure in which a small perforation is made in the floor of the third ventricle. So to create the cerebrospinal fluid pathway between the ventricle to the system. It is indicated for the treatment of obstructive hydrocephalus, like hemorrhage or brain tumor or stenosis of aqueduct. So the approach was made from the left anterior horn. This is the hematoma in the left anterior horn. It's aspirated. So it is very comfortable because it is very easy to aspirate a soft hematoma. Yeah, it's very comfortable. It's a lateral ventricle and the posterior horn. So this is a colloidal plexus. So sometimes the ventricle are filled with the water for observation. The foramen of Monroe can be clearly seen in this. In the water fields. So hematoma in the third ventricle can be seen. So from here, we use the flexible scope. If we want to proceed into the third ventricle, flexible scope with a bendable tip is useful. So this is in the third ventricle. This is the mammillary body. So this just below the basilar artery underneath, and this is the aqueduct, and there the clot. This is hematoma. So a small amount of the hematoma can be sucked out with the flexible scope. So now, suction. So you can see the aqueducts. Yes. So this is the pineal recess and aqueduct. this is a hematoma in the fourth ventricle. So patient has an obstructive hydrocephalus due to the hematoma in the fourth ventricle. So we decided to perform the ETD. So this is a balloon catheter. The balloon catheter is used for perforation into the third ventricle floor and dilatation of the stomach. So this is a tense moment. There are basilar artery and the posterior cerebral artery underneath. So very little stoma, next stoma, and the hole is widened a little by this balloon catheter. Little by little, widen the hole, my stoma. So you can see this vessel is a basilar artery. The hematoma was removed completely. The ventricular drainage, which was inserted just in case, it could be removed the day after operation. The rehabilitation could be started on the second operation date, and prognosis was good. Thus, efficacy of endoscopic surgery is gradually being demonstrated. This paper, 2018, compare endoscopic surgery with craniotomy. It reports the superiority of the endoscopy with a significant difference in hematoma removal rate, operative time, intraoperative blood loss, and post-operative GCS, Glasgow Outcome Scale. So this paper compare endoscopy with stereotactic techniques and reports that endoscopy is superior in the term of the operative time, or hematoma removal rate, blood loss, and ICU stay, and neurological outcome. This is a review of the result of the endoscopic surgery. The number of cases, ICH and comparative surgery are vary, but all show the benefit of the endoscopy. In summary, there were many reports of improvement of functional outcome, reduce operative time, increasing hematoma removal rate, reduce the shunt dependence, and reduce the cost. However, endoscopy is not all good. There are also weakness of endoscopy. So this is the last slide. The advantage of the endoscopy, the before surgery, is possible to perform the procedure under local anesthesia and shorter operative time, and removal of intraventricular hemorrhage is possible, and shorter drainage time and shorter ICU stay, and it is therefore possible to reduce cost. On the other hand, the disadvantage, hemostasis, so bipolar coagulation is not possible. Hemostasis is not good, so patient on antithrombotic agent, medication, or with a coagulation disorder, we should be treated with caution. And very hard clot are difficult to evacuation. And cannot use the decompressive surgery. So therefore, they cannot use the treatment for extensive brain edema, brain swelling patient. And endoscopic, if intraoperative bleeding from the aneurysm or AVM is detected, the patient must be immediately referred to the craniotomy. So the advantage and disadvantage of the endoscopic surgery must be fully understood before it can be used effectively. As a neurosurgeon, I hope the effective of surgical treatment of ICH will be proven in the future. Terima kasih. Thank you for your attention. I look forward when your pandemic is over. Thank you.
Okay, thank you, Dr. Takeda, for such a very interesting talk. I guess most of us are actually working in the emergency department, but I know there are some maybe within the surgical field as well as a neurosurgeon from Malaysia. Most probably they're in this group as well. Do you have any questions to be asked to Dr. Takeda? I think endoscopic surgery is quite new. I'm not sure whether we have it here in Malaysia or not, but it's pretty interesting to see that you managed to suck out all the huge hemorrhage that is being detected in the CT scan. So how long in general do you take to basically evacuate all this a very huge intraparenchymal hemorrhage in general?
How long?
Yeah, the operative time. How long? Will it take longer than the usual craniotomy?
Usual craniotomy, about 3 hours. Only craniotomy, but my endoscopic surgery is about 1 hour. Yes, this operative time is very short.
Oh, okay, that's very interesting.
Yes.
Yeah. Okay. So do we have any question to be asked to Dr. Takeda today? So do you do this for every patient that come in with that kind of because I'm not a neurosurgeon, little that I know about operative intervention, but all these deep areas of the brain such as the putamen, thalamus, normally not many surgeons would dare to go in, and normally the best management that I can offer will provide intraventricular drainage for the patient. So in Japan, do you have like a protocol for what are the type of patient that selectively you will go in for this endoscopic treatment?
indication,
Yes.
endoscopic
Yeah.
treatment. Yes, this is not too severe patients for couldn't decompression. So about the moderate patient, yes, severity, and mostly indicated the amount of the IVH is very good indication for this surgery.
Okay, okay. So you mentioned that if a patient has a ruptured AVM or the patient has aneurysm, it will be difficult for you to proceed with the endoscopic treatment, correct? So yeah, AVM, yes. So before going for this endoscopic treatment, they will have, is it mandatory for you to go for a CT angiogram to see whether there is a probability of a ruptured aneurysm or AVM?
Yes, usually CT angiography was performed before the surgery.
Okay.
But micro AVM is not detected in the CTA. So this is very dangerous.
Okay.
Yes.
All right. So currently in Japan, well, I've came back to Malaysia for almost 10 years, more than that. Is this a widespread current treatment, which is a standard therapy in worldwide in Japan? Not worldwide, sorry, in nationwide in Japan?
Okay. One more time. Okay.
Is this the standard treatment that you normally perform in the whole of the Japan, okay, throughout the country?
Yes, yes, yes. This is a very standard treatment.
Wow.
Particularly in Japan, is endoscopic surgeon is yes, endoscopic is popular.
I see. That's very interesting to know that. So, any further questions from the floor?
Hey, Dr. Takeda.
Hi.
I'm Chow from Penang. I'm an emergency physician as well. So thank you for the wonderful lecture. So I'd like to ask you, is there any specific target BP that you need before going in for surgery? Thank you.
Target BP?
Yes.
So for surgeon, we want to the lower than the guidelines. Yes, about so
120.
20, yes, mercury, yeah, lower the 20.
More than the targeted.
So it's not evident. Yeah, yeah, it's surgeon's impression. Yes.
All right. Any more question? Does that answer your question, Dr. Chow? All right. I had the opportunity to rotate in a neurosurgical department during my final year, during my 6th year of in medical school. A very exciting department. Most of them are men, but with soft hearts. Very kind people. All right. So if you have any more question, if not, I think I would like to end the event. I mean the CME for today. Okay, 1, 2, 3, 4, 5. Okay, so I think that's the end of our CME today. But because this will be the last CME of the year of 2021, hopefully we'll have more CME for the following year. I would like to encourage everyone to switch on their video so that we can take a photo shoot. So yeah. Just everyone switch on your video so that we can see your beautiful and handsome faces as a memorable snapshot for us. And we'll put it inside the Facebook of Neuroemergency SIGs. Okay, I can see there are also from Japan, Dr. Toshio Fujiwara. Please switch on your videos, Dr. Miyuki. And a few emergency physician, Dr. Anas, And my IMOs as well, all the way from Borneo, Sabah, Sui. All right. Okay, so I'm gonna go on now. All right. Okay, 1, 2, 3. Give your lovely smile. All right. Okay, great. Okay, second page. Okay, 1, 2, 3. Okay, thank you very much, everyone. So I think that's about it, and we hope to see you next year. Have a good day to everyone, and thank you for supporting. Bye.
Thank you, Nina. Thank you, Prof.
Thank you.
Thank you.